Cholangitis. Okay, I know it sounds pretty complex, maybe even a little scary, but what if I told you it's basically a plumbing problem inside your body? Seriously, let's dive in and break this whole thing down.
So here's the official medical definition. Acute cholangitis is an ascending bacterial infection in association with partial or complete obstruction of the bile ducts. Phew, that's precise, it's clinical, and it's definitely a mouthful.
Right. What does that actually mean in plain English? Well, to really get it, we need to stop thinking like doctors for a minute and start thinking like plumbers. So let's get right to the heart of it, the bile duct blockage. Just imagine your body has this really critical plumbing system. We're about to see what happens when that system gets clogged up and things start to go very, very wrong.
You know, cholangitis isn't just caused by one single thing. It's a two-part problem, a perfect storm, really. You need bacteria hanging out in the bile ducts, and you need something physically blocking the flow. You can have one without the other and be totally fine, but when you get both happening at the exact same time, that's when the trouble really kicks off.
So what's causing that blockage? Well, the number one culprit, by a long shot, is gallstones. But other things can create that traffic jam too. Things like a narrowing of the duct itself, that's called a stricture, or even certain parasites or medical devices like stents that were put there to help.
And once that blockage is in place, who are the bad guys that cause the infection? Well, it's a lineup of some of the usual suspects in the bacterial world like E. coli, Klebsiella, and Enterobacter. A lot of these are bacteria that normally live in our gut, but when the bile can't flow, it just sits there, stagnant, creating the perfect breeding ground for them to multiply like crazy.
Okay, so we've got a pretty good idea of what causes it, but how do doctors actually figure out what's going on inside? This is where it kind of turns into a medical detective story, with doctors using different tools to piece together the clues.
The first clue almost always comes from an ultrasound. It's super quick, it's non-invasive, and it's great at spotting things like gallstones or seeing if the ducts are swollen up. But it often has a tough time pinpointing the exact spot of the blockage. It's kind of like finding a smoking gun but not the person who fired it. So, to get a much clearer picture, the detectives bring in a more advanced tool, the MRCP. You can think of this as creating a super detailed 3D map of the entire plumbing system. It is, by far, the best non-invasive way to see exactly where the problem is. And this leads us to the absolute gold standard investigation, ERCP. Now, this is the master key in the detective's kit. And why is that? Because it's not just for looking. It can diagnose the problem and fix it all in the very same procedure. It is a total game changer. Finding the blockage is a huge step, but now the clock is really ticking. It becomes a race to fix the problem. The key word here is decompress. Doctors have to relieve that dangerous pressure building up in the blocked system, and they have to do it fast.
The initial plan is a really clear two-step process. First things first, stabilize the patient. That means getting powerful IV antibiotics flowing to fight that infection, and plenty of fluids to get them rehydrated. Then, step 2, the moment they're stable enough, relieve the pressure. You've got to drain that duct. And I really want to stress this. This is an urgent situation. For any patient who isn't getting better with those initial treatments, this whole thing escalates into a true medical emergency that requires immediate decompression. This is not something you can wait and see on.
So how do doctors actually go about decompressing the system? Well, they have a very clear hierarchy of options, a sort of treatment ladder, starting with the most effective and least invasive choice.
And no surprise here. Right at the top of that list is our star player again, ERCP. It's the procedure of choice because a specialist can use it to do some amazing things, like make a tiny cut to open up the duct, literally pull a stone out, or place a tiny tube called a stent to prop it open. The result? Immediate decompression. Problem solved.
But what happens if ERCP isn't possible? You know, maybe the patient's anatomy is a little different because of a past surgery, or maybe, for whatever reason, the procedure just doesn't work. What's the backup plan?
That backup plan is called PTC. Instead of going through the mouth with a scope, this procedure goes directly through the skin and the liver with a needle to place a drainage tube. It's a completely different route to get to the exact same goal.
So when would doctors choose this route? Well, they'll usually go for PTC if ERCP has already failed or it just isn't available. Or sometimes if the blockage is in a tricky spot that's hard to reach from below, like way up high inside the liver.
And finally, if both ERCP and PTC are off the table, there is one last resort,
open surgery. This means an operation to go in and manually place a special drainage device called a T-tube directly into the bile duct. It's definitely the most invasive option, but it can still be an absolute lifesaver.
So, to bring this all together, here's the key thing to remember. Cholangitis boils down to a simple but really dangerous equation. It's a blockage plus an infection. And the treatment follows a very clear logic. First, you stabilize the patient, and then, as quickly as you safely can, you drain that obstruction.